And hi, everyone. Welcome. My name is Edwin Huaychacon from Canada Health Infoway, and I'm so glad that you could join us for our second session in our Connected Care in Action series, a national conversation about real innovations improving care across Canada. Today's session, From the Ground Up, Community-Driven Innovation in Underserved Settings, focuses on something that doesn't always get the spotlight. How digital health innovation often begins not in the boardrooms, but in communities, shaped by those closest to care gaps, providers, patients, and local leaders. Across the country, these innovators are building tools rooted in equity, trust, and cultural relevance, making a tangible difference where access has long been a challenge. Infoway's Center for Clinical Innovation in Digital Health, something I called CIDH, launched in 2024, and it's here to support that work, to help address fragmentation, to promote interoperability standards, and get to the point of sharing knowledge so providers, whether in urban hospitals or remote nursing stations, have the tools to deliver high quality connected care. Some of today's initiatives are supported by the Connected Care Innovation Grant Program delivered through the CIDH. And today, you'll hear directly from the people doing that work. So let's meet our panel. First up, Dr. Daniel Pepe, a family physician in London, Ontario, and one of our 2024 CIDH grant recipients. Daniel and his clinic team built a self-service primary care model that turns all of those messy, unstructured EMR messages into clean, standardized summaries. The result is a secure portal where patients can quickly find what they need. A round of applause for our Dr. Daniel Pepe. Next, we have Dr. Ivar Mendez, Director of the Virtual Care and Remote Presence Robotics Program at the University of Saskatchewan. Dr. Mendez is leading the creation of the Virtual Health Hub at Whitecap, Dakota Nation. When it opens in 2026, it'll expand to connect up to 90 remote and Indigenous communities with real-time care using virtual tools, AI, and remote presence robots, supported by a new Indigenous workforce training pipeline through the Saskatchewan Indian Institute of Technologies. Then we have a Dr. Salim Samanani, a public health physician and founder of Okaki, a health informatics social enterprise in Alberta that now supports over 50 health centers and 120,000 clients. Okaki's Care EMR has been adapted to support nurses and broader care teams as primary providers, and most recently has advanced automated discharge planning to improve continuity of care. At Saddle Lake Cree Nation, a 2024 CIDH grant recipient, care was securely linked to Alberta's provincial systems, ensuring local providers could access medication profiles, hospital alerts, and records in real time while keeping community governance at the center. And finally, a close friend of mine, Dr. Rashad Baya, is a family physician and senior clinical leader here at at Canada Health Infoway. Rashad straddles two worlds, the realities of frontline care and the big picture work of national digital health strategy. The CIDH is very much his brainchild. He championed the idea from concept to reality, creating a national hub that not only advances interoperability, but also fuels innovation from the ground up. So before we dive in, please use the Q&A feature at the bottom of your screen to submit questions at any time. We'll answer as many as possible in the final portion of the webinar. Hopefully, we'll be able to answer a few there. And with that, I think we can get started. So, as we start today, I wanna start with a big idea that came up again and again while preparing for this session. And it's that innovation doesn't just happen to communities, it happens with them. And when it's done well, it's done for them. Across Canada, we're seeing powerful examples of what this looks like. For example, there's the Indigenous Digital Health Ecosystem, or IDHE, which is a nation-based platform being co-developed with First Nations, enabling communities to own, govern, and use their health and wellness data in ways that reflect local priorities and values. Unlike top-down rollouts, IDHE is shaped by local culture and designed to integrate with everything from EMRs to housing and social supports, centering Indigenous control, knowledge, and leadership. In rural and remote British Columbia, the Maternity and Babies Advice Line is reconnecting Indigenous families with culturally safe perinatal care, reversing decades of medical evacuation policies that removed expectant mothers from their communities. Co-developed by the First Nations Health Authority and guided by elders and midwives, it allows community providers to connect their clients to on-call physicians and midwives 24/7 via phone or Zoom. And to cap it all off in urban settings in Ontario, where I'm from, Scope, or Seamless Care Optimizing the Patient Experience, is a virtual program co-designed by family doctors to support solo practitioners. It gives one-stop access to specialists, nurse navigators, and community care, helping family physicians arrange timely care without sending patients to the ED. So these aren't just pilots. They're proof that when we listen to communities and build with them, we get better outcomes, stronger systems, and more equitable care. And in many communities, that trust isn't built only with physicians, it's built with nurses and broader care teams who are often the backbone of local health delivery. That spirit of listening, of co-creation, and of trust is what today's conversation is all about. So, panelists, from your experience, what does it take to build that kind of trust and partnership where communities aren't just users of technology, but co-creators of it? Maybe we'll start off with you, Dan.
Thanks, Edwin. I mean, I think it's interesting that when you talk about scope, because when I had talked with Dr. Paris or about the creation of scope, really that just came from a need, which was we can't get timely testing. And so she's like, okay, well, what test can't you get? Ultrasounds for DVTs. And then we just built from there. And I think in our practice, we do the same. We look at what's challenging. What's the point of friction that you keep hitting your head against day in and day out? We're frustrated by it. Patients are frustrated by it. We go, okay, this is the one thing we're going to focus on because it's very easy to say, we're going to create a revolution, we're going to innovate, we're going to redesign the healthcare system. But healthcare redesign is just little steps taken every day. And they can't just be taken for one person. They can't just be taken for the doctor. They can't just be taken for the nurse. They have to be taken for everyone because sometimes what happens is I do something that's good for me, but it makes more work for the patient or it makes more work for my staff, and that's not helpful. And so I think when you sit down with everyone around a table or you iterate over time with them, that's how you really start to move things forward. Is you say, what's painful for you? And then you understand that. You say, what's painful for me? And then you say, well, is this a good compromise in the middle? Because I think a lot of times the it's not technical debt, but it's process debt that we accumulate is just people making decisions for themselves that benefit them over time. And we forget that there's other people that make up the system we interact with. So that I think that's where I would kind of start my thoughts.
I think that makes a lot of sense. Making sure we're having those conversations with those stakeholders and understanding, what exactly can be accomplished through our conversations.
Yeah.
How about we go to Ivar?
Yeah, thank you, Edwin. So I think it's absolutely crucial, especially when you are dealing with indigenous and remote communities, to truly understand their clinical needs. You need to understand what are their clinical priorities, what are their clinical gaps, what do they actually need in terms of providing a solution. In co-design with individuals and the members of the community, the leaders, their healthcare teams, the solutions that will actually make sense for that community. And specifically in terms of indigenous communities, you truly need also to understand their autonomy issues, their cultural reality, their way of doing things. And I feel that a fundamental aspect of any intervention in those remote or indigenous communities is to actually build the capacity of these communities where members of the community themselves are an integral part of the solution. that is what building trust is all about. And we need to understand that before any intervention is proposed or applied.
Thanks, Yvonne. I really think you hit the nail on the head there. You know, co-design, working with these communities, making sure we're understanding those clinical needs is as how we're going to move that yardstick. Sal, how about you? Anything to add?
Thanks, Edwin. Good morning, good afternoon, everybody. Um, I'm certainly going to echo my colleagues' points there about really understanding pain points, about working with people, not for people. But I'll try to maybe add a point and not repeat what they've said. When it comes to Indigenous communities, you have to think about a relationship-based approach. That's what, if you ask what is trust, trust is about relationships. And many of us, most of us who are educated and go through our system, we tend to be very outcome focused. And so we always think about what we're trying to achieve and the outcomes we're trying to achieve, even in the problems we're solving. And we don't think about the process and the relationship. And I think an Indigenous way is a relationship first and a process first. You'll often hear do things in a good way. And that's not natural and intuitive for people. We think, all right, we'll focus on an outcome. And if we're doing something that solves a problem that's important, things will go well. But in fact, it's the opposite, that you have to first focus on the relationship and the way you're engaging and the process. And if you do that, then maybe you will have success with the outcomes, but not without that. So it's a different paradigm. So maybe I'll just stop there.
No, I think that's great, and I think that really is like as we go through the rest of the webinar and we go through our series of questions, that idea of a relationship first, a relationship based approach, I think is very critical to a lot of the problems that we're trying to solve. Maybe I'll go to you, Rashad, to end us off for this question before we jump into the rest of the questions that we have here today.
Sure. I mean, my panelists, co-panelists have made such excellent points already. Building trust and relationships in healthcare is so critical to the success of any initiative, particularly digital health initiatives. Ideally, in an ideal world, communities must be engaged. Clinicians who will be using the tools must be engaged. Patients must be engaged. There's one quick example from the early days of the Prescribe It National Electronic Prescribing Service initiative that actually Dr. Pepe is involved in or was. When we were developing the early business case and more importantly, the practical clinical use case based on the state of EMRs back in 2017, the idea of true integration of that product into EMRs was based upon recommendations from early engagement, early clinical focus groups. We sat down with clinicians and asked them to brainstorm, critique, ideate. And that's how we came up with not going in one particular direction, but going in another direction. So, that engagement, those partnerships and building that trust and early relationships, very important.
Thank you, Rashad. I think that's great, and I got to say thank you, everyone. I really appreciate all of your insights that you've already shown today, and I got to say I think we got it right with bringing together this group of panelists to talk about this issue. You guys all have such amazing experience and insights, and are driving incredible innovations within your own communities as well. So, with that said, let's shift from the big picture to a real world example. A clinic-based innovation that's improving access, reducing friction, and giving patients clear insight into their care. Dan, you and your wife, Dr. Cassandra Lean Pepe, developed this model during the pandemic. It was born out of necessity, but shaped by years of frustration with traditional systems. Can you walk us through, your project, self-service primary care, what it is and what's the problem it's trying to solve?
Yeah, thanks, Edwin. And I would say if anyone has questions or comments, feel free to jump in because I'm not a sit around and present and just let people listen. But self-service primary care kind of came out of the need of the fact that we had 2,000 people, tons of referrals, tons of prescriptions, tons of processes and care that we wanted to deliver because every year, every month, there's more guidelines.
Mhm.
about colon cancer screening, breast cancer screening, making sure that you're following along people's metabolic health, tracking their meds, and the amount of work was just simply overwhelming. And as Rashad would know, we had looked at for years of trying to figure out how do we integrate our native EMR system, tell us with some of these other tools, and you hear about APIs and you hear about integration, you hear about roundtables and data governance and structures. And what we started to realize is even if we integrated all of the data in our EMR with some tool, we wouldn't actually be any further ahead. And so the assumption we actually kind of came to challenge was maybe all the data, if I can even call it that, that we've accumulated in EMR is not actually that valuable. Because if I took on a new patient and they had come into our clinic in London, we would fax for their old records. But would I read through every single page of those 300 or 400 page PDFs for each of the 2,000 patients? The answer to that is no. There's really a couple key things that most people start with if you don't have access to someone's records anyways. Who are you? What are your demographics? What are your basic medical history? What are your allergies? Do you take any medicines? And you kind of build a record from there. And so the thought was maybe what we could do is just extract a core set of data out of the existing EMR and start fresh with, to Sal's point, really building a relationship and asking what are the actual things that real people want? What are their needs? And to Dr. Mendez's point, when he's building his team at the community, what do you need to actually have to build a good relationship? And so the thought was if we could extract just the basic set of information from the EMR, put it in front of patients, would they actually then, if given the tools to order a mammogram, to order fit screening, to order routine labs that need to be done every 2 or 3 years, could they help us with the work? So that we weren't doing all the work by ourselves, because the thought was if we could delegate or share some of that work with our patients, they would be motivated because then they're in control of their own health. They get a view of their own health record. We get to do more screening at a population level. And the eventual hope is we can actually take more patients. Because if I'm not pushing every rock up every hill for every patient, then all of a sudden I have capacity. So my likelihood of burning out is less. My enjoyment with work goes up. My patient satisfaction goes up because they actually get to see their results. They get to see their lab tests. They get to see what's being ordered for them. And now they're active participants in care. So I think when everyone was talking about the intros and the importance of a relationship, that's critical. And as a family doctor, our relationship is everything. When people ask what we sell or do, I always say it's trust. We just sell with patients and we work alongside with patients to build trust with them. And so what the
Mhm.
portals really allowed us to do is actually give them some autonomy back. And as we go through piece by piece by piece, we just keep delegating more of those roles to patients. And so it just increases our capacity. But the problem we were really solving was that interoperability problem. And
Mhm.
I think the
Mhm.
fixed assumption we had was that we needed to use our existing EMR and that there was no way out of the existing EMR. And unless we integrated into it, then we were stuck. So we thought, let's just pull out the core set of data, build a new modern set of tools, and go from there and really just focus on what we can do to build the relationship with patients.
Mm. It seems so intuitive, right? But we
Yeah.
know it's not the case for most. Even today, only 12% of primary care providers in Canada routinely share digital visit summaries or test
Yeah.
results with patients. But
Yeah.
at the same time, 85% of Canadians say they want online access to their health information, but fewer than half feel like they actually have it. So,
Yeah.
and when your patients started seeing their care records and test results for themselves,
Yeah.
what changed? You mentioned patient satisfaction went up. What do you think changed?
So I think a couple things changed. One is we got more inquiries about what does this all mean? And I think that's what everyone is
Mm,
afraid of. Everyone's afraid of, well, if I share the record and
hmm
then they see the red thing and then they call me about the red critical result, how do I talk about that?
hmm
And I think when you do it in the context of a trusting relationship, you quickly can build capacity with your patients and say, yes, that's red, but it's red because of this, and this is what we saw. And then that even further enhances the trust because now they know that you're not hiding anything. You're operating in full transparency. The other thing is, I feel like I've gained partners. So when my patients are looking through their reports, they go, oh, the specialist said I'm supposed to do this, but it looks like they never followed up with me. And I go, oh, okay, well, let me send a letter and we can follow up with them on that. Or they say, they recommended that I have another MRI in 12 months, but I don't really want to. Do you think I need one? And I go, I don't think so. I mean, we're just following this 2 millimeter aneurysm that probably isn't going to change in your 80, and you
hmm
go for the MRI anyway, so let's leave it. And so all of a sudden, all these things that were like make work projects that we would have to track over time, patients are getting involved in the decisions and going, yeah, okay, I want to do that, or I don't want to do that, or they never talk to me about that result. Can you explain that result? And all of a sudden they're engaged. So I know there's this fear that if we share everything that we have, people will see our mistakes, or they might see something we missed or something we didn't capture. And I think that's really just us defending our egos, because in order to practice
Mm,
medicine, you need a bit of an ego of confidence to say, yes, this is the right thing. And so it's a very humbling experience to actually share the results with patients. But what I found over time is there's a lot of trust. And it's also a bit of a fail-safe because we have referral
mhm,
tracking that we do that takes my team, I don't know, 4 hours a week, where they've got to fax all these doctors. Did you see them? Do you have a note? And now my patients know if they don't see a result, they actually ping our office and say, hey, I don't have the result. Can you follow up on that? Or where
mhm,
did that ultrasound go? Or you said I was going to get a mammogram in 4 weeks. It's been six. So that's a really useful tool, even from a public accountability standpoint, because now patients can actually see what's going on and they know what's happening and they have a way to access us. And for us, the other interesting thing is we've been able to kind of collate all the incoming fax inputs into the office and phone call inputs into the office. And we can actually tell what people are calling about. And about
mhm,
30% of it is people just asking about their results.
mm,
You have this test, you have that test, that this lab test gets sent. And I look at it and I said to my team, I'm like, if we can improve our processes, we can free up 30% of our time just by sharing this information with patients. And the other thing that I always think about in my head when doctors will say, well, you shouldn't share everything. My answer is if a new doctor faxed my office and said, Edwin's left your practice, he wants a copy of his records, what do? I
mhm,
fax the entire thing. I
mhm.
would do that if someone requests a record, then what is the barrier to actually sharing today? The answer is there is none. It's a cultural thing. And we have to kind of get over that and bring patients along for the journey because it's their health, it's not ours.
Amazing.
So
Thanks, man. I really appreciate that. And
a little long-winded, but
we still got 40 minutes left.
okay, good.
A
Okay.
little bit, but we'll make sure we can be quick with our other questions. But I really think you hit the nail on the head. This is really a relationship-based approach, kind of similar to what Sal was saying earlier, right? Like building that relationship with patients. Ultimately, at the end of the day, improves health outcomes for them and improves the workload for yourself as well.
Yeah.
Rashad, from your professional perspectives, both as a practicing clinician and as a clinical leader at a national organization, what makes these kinds of solutions that Dan mentioned sticky and stay sustainable over time?
Sure. Thanks, Edwin. Great question. And first, kudos to Dr. Pepe, Dan, and his partner, Dr. Lynn Pepe, and team for all the excellent work they've been doing. It's been a real honor to be able to participate in support. Uh, I will try to keep the answer to this relatively short and simple. To make these kinds of solutions stick over time, they really need to stand up to a few criteria, many of which Dr. Pepe has really nicely reflected on and are represented in his initiative. So number one, they work well and they're reliable. So they produce predictable, reliable outcomes each time they're used. Number two, they are intuitive and easy to use. So the learning curve cannot be too steep. And often this means that the technology may be iterative, sometimes, as Dr. Pepe has mentioned, building on existing hardware and software that is already working. And number three, they make life easier, better for clinicians and patients and communities. And again, in a way that is reflecting back on number one and number two, reliable and simple.
Perfect. Thank you, Rashad. Works well, intuitive, and easier and better for the users. That's great. Now, Sal, you've worked with providers and health systems across Alberta and beyond, often in Indigenous communities and underserved or rural contexts. What principles from Dan's model apply to the work that you're doing, especially when it comes to leveraging technology to improve care delivery and planning?
There were so many important themes in Dan's, I mean, he touched on um, really the role of the clinician as not just an expert, but a helper. He touched on the themes of engaging patients and empowering patients. He touched on, the satisfaction of patients and provider satisfaction. I mean, there's so many things packed in there. But as you said, it comes back to really the fundamental root question is how do we strengthen that relationship between patients and providers? And I think, unfortunately, while digitization of healthcare has had a lot of positive benefits, and most would say, this digitization is essential to really transforming services. It has had the unintended consequence of bogging down the entire healthcare system with documentation and other processes. And I think we're starting an exciting era where we're going to reverse that. I think the last 30 years has been focused, or 20 years, on this digitization of healthcare, and now it's about like how to reclaim time back to allow that human beings to connect in a deeper way. I literally am in a context where there is a shortage of healthcare providers. So we support 50 First Nations home care programs. And I know every one of 500 providers, and universally, each provider is having to choose between delivering care and spending time with their patients versus completing the documentation requirements just to make referrals, to submit reporting, to comply with, professional standards, and they're having to choose, and that is painful. So, I think the first step for me is asking, how do we let people be healthcare professionals again and connect with their patients, and how do we give them the time to have those, face-to-face and deep relationships, and all the problem solving is around that. And I think, Dan gives a great example, and we could, I think, spend a whole hour just on this topic, but I'll stop there.
No, that's great. And it really is like you said, we're entering this new era where we can really start to leverage technology to get time back to make sure that we're focusing on the things that matter most. And that's that patient experience, that patient care, that one-to-one dialogue that takes place. Ivar, you're designing the virtual health hub to bring care directly to Indigenous and remote communities. Do you see any elements of Dan's model that align with what you're building, particularly when it comes to clarity, trust, or patient empowerment?
Yeah, absolutely. The delivery of healthcare using digital technologies is a multi-pronged approach. And one of the things that Dan clearly has demonstrated is that, we as physicians have had this traditional sense of the physician-patient relationship. Somehow, over time, we have forgotten 50% of that relationship, that is the patient. We have forgotten that medicine is a profession of service, and a profession of service to our patients, not to ourselves. And a lot of times are the physicians themselves the barriers to sharing and be transparent about the healthcare of the patients that we're treating. This seems to be like a no-brainer in terms of that idea, but it has been over time. Dispersed by ourselves, the physicians. So, we don't have to reinvent the wheel all the time. We can apply, this really implementation that Dan has done during the pandemic and has been now maturing to what we do. We have to learn from each other, and this is a perfect example of this.
Yeah, and I really like how you positioned it. The at the end of the day, your relationship with your patient is 50% of that. And some people have forgotten that other half is just as important and when it comes to treating patients. So, folks, the audience, it's a great reminder that when innovation starts at the front lines with people who understand the pain points firsthand, the impact can reach far beyond a single clinic. And that brings us to our next segment. What happens when we apply that same principle to some of the most remote and underserved regions in the country where access has long been a constant barrier? People in these communities are nearly twice as likely to report unmet healthcare needs. Some folks travel hundreds of kilometers for a single appointment, and even with travel subsidies, many still put off care or skip it altogether. That's where virtual care, when done well, can be transformative. Studies show it can reduce wait times by over 60%, improve continuity of care, and strengthen trust when it's grounded in local partnerships and culturally safe models. Ivar, you're leading the development of the virtual health hub at Whitecap, Dakota Nation, a national first. And from my understanding, it's a centralized facility that will serve up to 90 communities using remote presence robots, AI, and real-time diagnostics. It's Indigenous led, co-designed with community partners, and paired with a workforce training pipeline through Saskatchewan Indian Institute of Technology. All of that to say is, nothing major, I guess, just transforming healthcare as we know it. It's incredible work. And in all seriousness, can you start by maybe sharing the vision behind the hub and why it matters?
Yeah, thank you, Edwin. So it actually starts from the ethical imperative to provide service to the most marginalized
Mhm.
and underserved populations in our country. And these are indigenous populations, the places that live in the north, that live in remote areas. So we really also combine that ethical imperative with this philosophical shift of the model of healthcare that we currently have in Canada, which is a centralized model. And the issue of this centralized model is that it's actually not working.
Mhm.
Although we're spending more and more resources in healthcare, most of the provinces spend almost 50% of their budgets in healthcare. The quality of healthcare continues to decline. I've been in practice as a neurosurgeon for over 30 years, and I can tell you for sure that I haven't seen a crisis of healthcare as we have now. About 15 to 16% of our population do not have access to a primary care physician. Um, we have a 70,000 person healthcare gap in the country, all the way from nurses to technologists. And the other issue is that this gap is hard to fulfill. So, we have been really working and truly to understanding first that I don't think we continue to do the things that we've done in the past. We don't have any other option but to change the model of healthcare in the future because our current model is inefficient and unsustainable. And this is really the work of the Virtual Health Hub. We're focusing on these most marginalized populations, the people that have the least and need the most, and trying to build a model that can not only be used in Saskatchewan and beyond, but that can be a model that can be scaled up nationally and hopefully globally.
Yeah, you're right. And you know, as you were speaking, it made me realize and think about that when we talk about technology and emerging technologies, we need to make sure that these technologies are developed in a way that not only have the patient first, but also doesn't leave anyone behind, especially those that are the most marginalized across the country. Can you give us a real world example of, what does it mean for example, when an expectant mother can get an ultrasound in her own community?
Yeah, so you may know that the Indigenous population of Canada is growing at 4 times the rate than the
Mm,
rest of the population of Canada. We have high rates of teenage pregnancies in a lot of our Indigenous communities. And when you look at the mortality rate for mothers and newborn babies, is really high in comparison to the South. And the reason is that a lot of these women that do not have access to prenatal ultrasonography, that you need to be actually taken out of your community, go to a city, be put in a hotel without your family to have your ultrasound. So a lot of these young pregnant women do not have ultrasonography. So what we did is we did actually a study of all the pregnancies in Saskatchewan for a period of 4 years. And what we found was just remarkable. If you are an Indigenous woman that lives in a remote location, you have 65% less likelihood to have access to a prenatal ultrasound. So this was clearly seen in our studies. So how do you deal with that? So what we did is we pioneered the use of a technology that was developed by the European Space Agency to do an ultrasound in an astronaut in the European or in the International Space Station. So you can imagine if you're an astronaut in the space station and you have abdominal pain, before they send a rescue mission, they want to have some sort of diagnosis. So that's how they develop this robotic ultrasonography. And we have now deployed this system in about 7 communities in Saskatchewan. We're really the world leaders in robotic ultrasonography. And that has provided for the first time ultrasound access to these pregnant women. We do thousands of ultrasound exams, really at a fraction of a cost. So this is an example of how a technology can actually help narrow the gap of inequity in healthcare delivery to the most vulnerable populations, expectant mothers.
Ivad, I think I speak on not only on behalf of the panelists, but everyone on the call to say thank you for, such amazing work that you and your team are doing. It is really incredible work, and I'm excited to see, how it continues to evolve and impact more communities. Now, Sal, from your 15 plus years working with Indigenous communities, what lessons have you learned about making virtual care both clinically useful and culturally safe in underserved contexts?
Yeah, so maybe I'll use the example of diabetes. I always say
Mhm.
diabetes is a good case study in access issues and in challenges because it involves many specialties and quite a large team to provide care. And the pandemic certainly, one of the silver linings is I think it unlocked the willingness of governments to look at different models and virtual care models. So we've been at the heart, like looking specifically at access uh, for diabetes care for about a decade. And majority of our programming has been born in partnership with the community. And I think the one theme I'll share is to look at really as an opportunity to create hybrid models of care where you have primarily nursing teams on the ground or other community health workers, and then remote clinicians, and look at virtual care more than just a Zoom call or a phone call, but as a way for teams to work together, spread across, you know, uh, different facilities in different places, and just ask yourself, well, what does each person do well? And in this is the role of the community. So in our case, the virtual models have really tried to leverage community partners. It has needed to understand local capacity and, as Ivar had said earlier, invest in that local capacity in looking at care pathways, in looking at where the gaps are. And I'll give you one simple example. Most specialists are only paid if they get a referral from a family doctor or a nurse practitioner. Most provincial payment programs. So what happens if two-thirds of your northern communities don't have regular access to primary care?
Mm.
So how do you connect, these are system problems. How do you connect patients now to specialists if the only pathway is through a resource that there's not enough of? And so being open to direct from nursing referral pathways, to work with virtual primary care models to kind of supplement this. So there's not this nice, clean approach. And approaches are regional and they're geographic, and you have to kind of know the context in each, and you have to take time to understand what pathways work and to engage appropriately. So I think that's our approach right now. During the pandemic, we launched the province's virtual diabetes care clinic. And following this sort of grassroots approach, we're now, reaching. I think this last quarter we reached 600 rural postal codes for people, and most of which are facilitated through a rural facility of some kind and a nursing facility.
Hmm. Yeah, and I think it's interesting. Like there really is. There's so many layers. There's a complicated cake of issues where each layer requires different ways to address the situation. And I think when we talk about that system layer, we're gonna have to think innovatively and outside of the box to see like what are different ways that we can address this particular issue, right? How can we leverage other processes to resolve these problems? Rashad, from your national vantage point, we saw a rapid expansion of virtual care during the pandemic, something that Sal alluded to earlier. And we're now entering a new phase of transformation, a new era focused on digital health advancement and greater portability and access to health data. However, scaling technology doesn't always guarantee success. So, what does it truly take to ensure that health system transformation and the data that drives it works for communities, not just in communities?
Edwin, it's a great question. Thank you. And first, I just want to say, wow, again, just hugely impressed by the excellent work that Ivar and Sal and their teams have been doing, coming up with these practical solutions to very real challenges in under-resourced communities. And, Sal really highlighted how thinking slightly differently around different models of care can help to solve these problems. And I wish that could be universally the case. Their work and the challenges that they've highlighted, that they've overcome highlight how in Canada, health system transformation can be enabled by digital technologies, can involve a complex series of actors requiring lots of policy levers, which theoretically can be driven to succeed if you have a longer term vision of where we want to be as individual provinces, territories, communities, but also as a country to improve the care of everyone. So, in a country as complex as ours, and in the context of our federal, provincial, and territorial divisions of responsibilities, having policy driven by long-term vision, it's not easy to achieve. And if we use virtual care as an example and rewind to the pandemic days, virtual care was the hot topic in digital health and clinical informatics. For some reason in the public consciousness, we've forgotten it a little bit. It's fallen a little bit out of favor, around hype related to terms like artificial intelligence and even interoperability, all of which have great potential. However, all of these are part of the same spectrum within digital health. Good virtual care is enabled by solid interoperability of systems and can be further enhanced by AI-powered tools. They're not mutually exclusive. However, vision, policy, and political timelines have not necessarily aligned in order to make it really easy for clinicians to do the right thing and for patients to benefit from that. So, in the longer term, policy and visions can be informed by engaging with communities, patients, clinicians to truly understand, as Sal and Ibar and Dan have mentioned, what is required for sustainable change. So, if we keep at the forefront this principle of improving the care of Canadians through practical use of modern technologies, we can see positive health system transformation in the future that will work for people. Otherwise, we may see that a digital divide will continue to increase over time.
And I think that for sure that digital divide is something that we want to avoid. And unfortunately, we don't have as much time to kind of get into everything that I wanted to chat about. So we're gonna move on to the next section, where we're really focused on data that listens, right? So we've heard how virtual tools are reshaping care on the ground. But to scale those models and make sure they work across the system, we need a solid digital and interoperable foundation. Because no matter how innovative a model is, if systems don't talk to each other, patients fall through the cracks. And in underserved settings, those cracks are often the widest. In Indigenous contexts, there's an added dimension of data sovereignty, the right of communities to govern, control, and benefit from their own health information. It's not just about connecting systems, it's about ensuring those systems reflect and protect local priorities and values. And I think that circles back to that idea of that relationship-based approach. So, Sal, I know you were part of the team that supported Saddle Lake Cree Nation's Connected Care and Innovation Grant, which brought the community's local governed care EMR into secure connection with Alberta's provincial systems. From your perspective as both a provider and an industry leader, what aspects of this project stood out as most significant, both technically and culturally, in the way care is delivered? And how have you seen this work evolve since its initial implementation?
Yeah, thanks, Edwin. So there's kind of two questions in there, one related to data sovereignty and one related to enabling the flow of information through interoperable systems between care team members. So I'll tackle that latter one first. This has really been almost a 12-year journey, and it's a journey of recognizing the role of nurses in First Nations. Um, every First Nations home care, every First Nations in Canada has a home care and community health program staffed by nurses. They don't all have doctors. So, there's
Mhm.
620 First Nations. So let's start, with that point. And so if you don't recognize and appreciate the role of nursing in that primary care as part of that primary care team, that's an issue or a challenge. And so what I've seen over, nearly 15 years is, first of all, in 2011 in Alberta, our provincial privacy laws changed to recognize nurses as custodians of health information with the same authorities and responsibilities as physicians. And so that recognition actually is foundational because without it, it means you're not recognizing the right of nurses and a home care nurse caring for a patient to access information the same way as other care providers. I think, kudos to the province. The problem we're dealing here with Saddle Lake is a long-standing one. It is the horrible discharge planning process that exists today that relies on a unit clerk or a social worker on every hospital ward to know people at their local First Nation community and to reach out early, to connect with the home care nurse manager, to, discharge plan and understand the patient's context and have that good interaction, which no matter how many policies and procedures you put in place is never going to happen across a health system. And I have attended, hundreds of meetings on this over 15 years and nothing has ever changed. So the province, recognizing that, has put in a technology approach to solving this, which is every primary care provider is able to register a panel and information will flow automatically, not reliant on human effort to the primary care provider. So this infrastructure is really key. And again, hats off to the ministry here in Alberta for doing so. They they took the steps to now recognize on reserve that, hey, although this system was built for family doctors, we're going to adapt it and look at the concerns of nursing managers and primary care nurses. And one of them is their scope of practice is different. So I'll give an example: is nurses were not comfortable being recognized as the most responsible clinician, the one that, if someone is discharged and there's urgent labs or there's urgent meds, that they would have to do that. So although they need to know information, there's some responsibilities that are outside of their scope. So the system had to be modified. And the province made, they took those efforts. So I have to recognize them in doing that. But Family Day last year, this system went live. And on that weekend, the community that implemented this solution, which is what is the solution is automatic notification anytime a client touches a provincial hospital facility, an emergency room, or is discharged, not reliant on any human connection or interaction. So that weekend, the initial community that implemented this was made aware of 7 discharges they knew nothing about prior to that. So it was in the words of that clinician, it was a game changer. And so you asked how this has unfolded. Well, in 1.5 years here, with the support of also the federal government, Indigenous Services Canada, it has already rolled out to 2/3 of First Nations out of all of them. Like that's I've never seen anything go this fast, and it just because this is so important. It's solving such an important problem. On the issue of data sovereignty, well, again, I think that's an hour-long discussion, but
Yeah.
we manage data sovereignty in a very simple way. We recognize, so number one is the community is in control of their rosters. And um, that roster of who is actually part of their community allows them to assert their sovereignty, and they decide who gets information on those folks and who doesn't. And often, when we're working with our partners, people are really focused on one-way flow of information from community to the center for reporting and accountability purposes. But I think we're really focused on, okay, what information also has to flow back to a community for their rostered population so that they can care for that population, so they can assess the health of that population. And I really feel like we're just embarking on a new era here. It's taken us sort of 15 years to establish this foundational electronic health record infrastructure. And I think in the next 5 to 10 years, I'm quite excited about seeing what information flows back to communities to empower their capability to exert their sovereignty and plan and care for their own communities.
It's really incredible to hear the work that you've done, Sal and Ivar. Both of you have worked extensively with Indigenous communities through your respective programs. We don't have a lot of time left, so maybe in 60 seconds, from your perspectives, and maybe we'll go with Ivar first. How can we ensure that the design and governance of digital health and data systems not only enable interoperability, but also better support community priorities of self-determination, data sovereignty, and trusted partnerships with Indigenous peoples?
Yeah, Edwin, a crucial aspect is the building of the capacity of the community. One of the things that has been a pillar of the Virtual Health Hub is to train healthcare workers from the communities in using these advanced technologies. And one of the things that we've seen as an incredible surprise is that young people that are in high school that you may know that the rate of graduates in indigenous communities of high school is very low. Had gotten inspired by using space age technology to provide care to the communities. So building that capacity in those communities is absolutely crucial for the success of any program that would go. And of course, respecting the self-determination and the sovereignty of these communities. It's truly a co-design project that has the real chance of being successful.
Sal, is there anything you'd like to add to that?
I think I've spoken enough. Maybe I'll give Dan and Rashad an opportunity here while since there's limited time. I completely agree with what Ivar says, and I think it goes back to what we've touched on already.
Mm-hmm. So that's fair. And I think we've heard so many rich insights today. And before we wrap, I would like to kind of get some insights really quick. From Dan, for example, what advice do you think you would give other clinicians who are challenged by workflow gaps and are ready to start small?
Yeah, I think my answer to that is just look at your day, look at what you're doing, and when you feel that uncomfortable, painful thing where you just sigh a little bit and you're like, oh, again, that's the thing you fix. Or when patients keep calling about the same thing, that's the thing you fix. And to add to Avar's point and Sal's point about data sovereignty, I wrote something down. I said, think about the work and then design a system to protect the work. Because so often we start with designing all these protections and we have these long meetings about all these edge cases that never come to fruition. Just like say in an ideal world, this is what we want to see happen. and then build the structures to protect it, to run it, to keep it efficient after that. That's what we're trying to do. I'm trying to get away from all the stuff that we've just accrued over time and just say, if we had to do it tomorrow brand new and we had a blue sky, what could you do? So that's how I think about it.
That's great. And there are some questions in the chat that I'm hoping to get into. And I gotta say, I appreciate the audience and your engagement as part of today's conversation. So for our next question, what is necessary to scale local innovations from community-based pilots to broader system-wide adoption? Maybe I'll give it to you, Rashad, to answer that.
Thanks, Edwin. I'll try to be brief. I know we're running out of time, so I hope everyone listening on the call takes inspiration from all the great ideas you've heard here today. Canada, we are known to suffer from pilotitis in healthcare. Anytime a new digital health innovation arises, we really need to ask ourselves, is it scalable at the local, regional, provincial, indigenous nation, indigenous community level, at the national level? Um, Partners need to think beyond election cycles and beyond hype and focus on problems that our panelists have mentioned today, problems that need a solution, clinical problems that need a solution, or patient-facing problems that need a solution in a way that can be replicated and that are not necessarily tied into a specific tool or technology. So one key factor that we can try and remember is think big, think nationally, but act regionally and locally within your province, territory, or community to gain that initial momentum and traction. And that will increase the stickiness of an innovation. And some of this is what we're hoping to find in our clinician innovation grants.
Thank you, Rashad. And I gotta say thank you to all our panelists. We've covered a lot of ground today, from co-designed primary care models to virtual care delivery to digital infrastructure that ties it all together. And at the heart of each of these examples was the same theme. When communities lead, innovation lasts. And that's exactly what we're hoping to facilitate here at Infoway. We believe the future of digital health must be rooted in real stories like the ones we heard today, because that's how we learn, that's how we scale what works and build systems that serve everyone. To our panelists, once again, thank you so much for your wisdom, your work, and your time. Hopefully, we can all get together in person one day, maybe at our 2025 Infoway Partnership Conference. It's going to be taking place November 17th to 18th in Quebec City, where national and international thought leaders, innovators, and digital health experts come together to share ideas, tackle challenges, and shape the future of connected care. So I hope to see my panelists there. I hope for the folks that join, hopefully you can join us as well. Maybe find out what your favorite Quebec dessert is. You're going to hear a lot about the 2025 CIDH grant and scholarship winners there, and a lot of the inspiring work that's taking place across the country. With that, we'll see you at the end of September for the next episode of Connected Care in Action, where we'll explore Halo, a framework for bringing all the tools providers need into one place to cut the clutter, simplify care, and keep systems in sync. Keep an eye out for registration details coming soon, and thanks again for joining.
Thanks, everyone.